Welcome to Renal Care Podcast, a series dedicated to topics of interest to nephrology professionals. Thyroid dysfunction is a common and clinically significant comorbidity in chronic kidney disease, CKD. Evidence shows a complex, bidirectional relationship between thyroid function and renal health, with hormonal abnormalities becoming more pronounced as CKD progresses. These changes affect cardiovascular risk, disease progression, and mortality, requiring CKD-specific interpretation rather than general population norms. In CKD, impaired renal clearance, uremic toxins, inflammation, and metabolic disturbances disrupt thyroid hormone production, transport, and regulation. A key finding is reduced conversion of T4 to T3, leading to low T3 syndrome, often with normal or slightly reduced T4 and normal or mildly elevated TSH. This reflects altered hormonal set points rather than primary thyroid disease, and is often described as functional hypothyroidism. Thyroid dysfunction also impacts kidney function. Hypothyroidism reduces renal perfusion and GFR, increasing creatinine levels, while hyperthyroidism can mask renal impairment. Studies show abnormal TSH levels are linked to CKD onset and faster progression, reinforcing this bidirectional relationship. Typical thyroid profiles in CKD include low T3, normal or slightly reduced T4, mildly elevated or normal TSH, and increased reverse T3. These patterns resemble non-thyroidal illness syndrome, making diagnosis challenging. Low T3 is strongly associated with inflammation, malnutrition, and higher mortality. Thyroid dysfunction is prevalent in CKD, especially subclinical hypothyroidism, and increases with disease severity. It is often underdiagnosed, including in large studies like the German CKD cohort. In dialysis patients, abnormalities are more pronounced. Hemodialysis patients often have low T3 and T4 with normal TSH, while peritoneal dialysis may further reduce hormone levels due to protein loss. Interpretation must consider dialysis modality. Clinically, thyroid dysfunction contributes to cardiovascular disease, CKD progression, and increased mortality. Low T3 and elevated TSH are independent predictors of poor outcomes. However, interpreting thyroid tests in CKD is difficult due to non-thyroidal illness, altered TSH dynamics, and assay interference. Evaluation should consider the full clinical context, not isolated lab values. Screening is recommended in moderate to advanced CKD, especially with symptoms or unexplained decline. TSH remains the primary test, supported by free T4 and sometimes T3. Serial measurements are more useful than single values. Treatment is clear for overt hypothyroidism, selective for subclinical cases, and generally not indicated for low T3 syndrome, which is often adaptive. Thank you again for joining us here on Renal Care Podcast.